Welcome to my classroom. In today's lecture, I will be presenting a patient that comes into the emergency department with progressive dyspnea on exertion. I'm going to take you through their signs and symptoms, physical exam, and diagnostic workup as if you're the cardiology consultant. I will discuss how we come up with the diagnosis of acute decompensated heart failure and describe the plan that reflects guideline-directed medical therapy. I will also discuss how you will meet the criteria for the American Heart Association Get With the Guideline recommendations. This discussion will accurately prepare the nurse practitioner and physician assistant to create your patient's diagnosis and plan of care, in addition to giving you key points to help you pass the Certified Heart Failure Nurse exam. I'm Kate Morgan, and I'm an acute care nurse practitioner working in general cardiology, and I'm also a CHFN. So let's get started on the case study. So this is the book that I use for reference. Make sure everybody who is studying for the CHFN, Certified Heart Failure Nurse exam, gets this book. You can get it off of the American Heart Association of Heart Failure Nurses website. It is called the Heart Failure Nursing Certification Core Curriculum Review. So I'll be referencing a lot of material in this video and in future videos regarding in this book. So our first slide talks about the history of present illness. This is a 68-year-old male with a history of coronary artery disease. In the past, he had an LAD stent, this was done back in 2016. He has a history of hypertension, dyslipidemia. He's a former smoker, and he presented to the emergency department with progressive dyspnea on exertion over the past 2 weeks. He denies having any chest pain, no fever, chills, or cough. So we want to get a little bit more detail about his level of activity in the past and what has been going on over the past week or so. One of the big questions I like to ask when they're in the emergency department is, okay, these symptoms have been going on for a couple of weeks. What brought you in today? So again, just try to get the details about what's been going on in their life and their general health and how it has brought them to the emergency department. So this patient describes that his normal level of activity consisted of taking brisk walks around the neighborhood 5 days a week. Now he gets short of breath with normal activities of daily living. He also has noticed some bilateral lower extremity swelling, and he has to sleep propped up with 2 pillows over the past week. So laboratory and diagnostic data, vital signs, blood pressure's on the higher side, 168 over 88, heart rate 86, oxygen saturation a little bit low, 92% on room air, and he's afebrile. So the chest x-ray shows pulmonary vascular congestion and small bilateral pleural effusions. Now the image that I have on the slide is not from him, it's a stock photo. So that also, describes some things that you can see on a chest x-ray with a person that has congestive heart failure. His BNP is elevated at 978, and troponin is normal. Creatinine is normal, and also his complete blood cell count, potassium, sodium, they're within normal limits. EKG is normal sinus rhythm and no ischemic abnormalities. So his physical exam, neurologically, he's awake, alert, and oriented. No neurologic deficits. Skin is warm and dry. He's quite stable. Now, cardiovascular, he does have positive JVD, jugular venous distension, and it travels all the way up to the jawline. And when you press on his abdomen on the right upper quadrant, it actually fills up even higher and more prominently, and that's called the hepatojugular reflex. No carotid bruit. Heart rate is regular with regular rhythm. I did hear a 1 out of 6 systolic murmur to the apex. No rubs or gallops, no S3. positive 1 plus pitting lower extremity edema to the pretibial area bilaterally. Pulmonary, his lungs are diminished posteriorly with coarse inspiratory crackles bibasilar. Respirations are non-labored, and the patient is wearing 2 liters nasal cannula oxygen. So gastrointestinal, his abdomen is soft, non-distended, positive bowel sounds, non-tender, so I'm not concerned for any ascites or abdominal wall edema. His home medications include aspirin, 81 milligram daily, Lipitor, 40 milligram nightly, Norvasc, 10 milligram daily, metoprolol tartrate, 25 milligram nightly, and in the emergency department, he was just given IV Lasix, 40 milligrams times 1 dose. So now I want to discuss the New York Heart Association classification and what level we're going to give our patient. So New York Heart Association classification 1 and 4 are pretty easy and clear cut. 2 and 3 gets a little muddy. So 1 is no symptoms with ordinary activity, and 4, severe limitations with dyspnea at rest. So they're the opposite spectrum. Now 2 and 3, they're going to have some symptoms, but it just depends on how severe it is. So number 2, mild symptoms during ordinary activities such as walking or climbing stairs. NYHA classification 3, marked limitation in activity and only comfortable at rest. Now, of course, you also have to remember patients are not always simple. They have multiple comorbidities. So a patient, for instance, that has asthma or COPD or pneumonia, their level of dyspnea may not singularly be reflective of heart failure. It may be a combination of their other comorbidities. So what are we going to give our patients? So on the left, I just copy forward the NYHA classes 1 through 4, and on the right, I copy forwarded his chief complaint. So again, his normal level of activity consisted of taking a brisk walk around the neighborhood 5 days a week. Now, probably we should define that a little further. How long is the walk in terms of miles, and really how brisk is it? And what he tells us is that he easily gets short of breath with just normal activity of daily living at this point, and he has to stop just to rest and to catch his breath. So in this scenario, I'm going to give him an NYHA class 3, marked limitation in activity, only comfortable at rest. Now, the NYHA classes are not static. They're pretty fluid. So you can go kind of back and forth with treatment. So he may be coming in with a class 3, and after we diurese him, get the volume off, and get him on good medical therapy, we may walk him around the floor, and he's actually has no symptoms with walking around. So then, is he now an NYHA score of 1 at discharge? So now we're going to get the echocardiogram. And again, this is a stock photo, not reflective of an actual echo of this patient. So his ejection fraction is now noted to be 35 to 40%. Last echocardiogram was done 2 years prior and noted to have an ejection fraction of 50%. Now we know an EF of 50 to 60%, that's more in the normal range. So he also has mild global hypokinesis of the left ventricle, which in other words, we'll call that a wall motion abnormality. He has some mild mitral regurgitation, so that's probably the 1 out of 6 systolic murmur that I'm hearing to the apex. Also on the echo, it shows an impaired left ventricular relaxation pattern, also known as diastolic dysfunction, and this is a stage 1. Now, the inferior vena cava can reflect volume status, and in this echo, his inferior vena cava is moderately dilated, which suggests volume overload. So let's talk about the stages of heart failure, A through D. Now, this is more of a linear progression based on the structural anatomy of the patient. So stage A, there's no structural heart disease and there's no symptoms of heart failure, but they're high risk for developing heart failure with comorbidities such as diabetes, hypertension, coronary artery disease. Stage B, the patient has structural heart disease, but without any symptoms. Stage C is structural heart disease and prior or current symptoms of heart failure. The majority of the patients that I'm seeing in the hospital are stage C. And stage D, refractory heart failure requiring specialized interventions. So this is a patient that keeps coming in with recurrent heart failure, hospitalizations, despite all the medical management that we can provide. So again, our patient is class stage C and NYHA class 3. And our diagnosis here is acute decompensated heart failure with reduced ejection fraction. Now, in a previous video, I discussed how you define heart failure with reduced ejection fraction versus preserved ejection fraction, and basically an ejection fraction of 40% or less is considered systolic dysfunction and reduced EF. Now, the patient has also some diastolic stage 1, so technically it's combined heart failure. But I would list as your ICD-10 diagnosis is acute decompensated heart failure with reduced EF. Now, what supports our diagnosis? Clinical symptoms of progressive dyspnea is number 1. Orthopnea, the fact that he has to now sleep propped up on 2 pillows, and even some patients will tell you, well, now I have to sleep sitting up in the recliner, or I really can't sleep much at all. That's usually the tipping point at which they come into the emergency department. Another exam finding that would support our diagnosis that I didn't mention in this patient is PND, paroxysmal nocturnal dyspnea. So that's a sensation that they suddenly can't catch their breath in the middle of the night when they're sleeping. So other things in this history that support our diagnosis are his exam findings of JVD and hepatojugular reflex. That is very sensitive for volume status, so make sure you're checking that, and it's quite a skill to be able to detect that. Some patients are really difficult to see. And crackles, of course, although I've had plenty of patients with pleural effusions and you really don't hear crackles and you're relying on your other data, your chest x-ray. And of course the fact that he has some swelling in his lower extremities and a slight murmur. Another thing to look out for is an S3 heart sound. That's also indicative of volume overload. Elevated BNP, which he has, and again, chest x-ray with pleural effusions and pulmonary vascular congestion. So your diagnosis of heart failure is a clinical diagnosis, but your laboratory and diagnostic data is there to support you. And again, a lot of patients aren't this simple. They have other comorbidities, like they're coming in with fever, cough, and an infiltrate as well on their chest x-ray. So we kind of have to tease out those things. So now the plan. The plan is quite extensive, and for someone that's coming in with new onset heart failure with reduced ejection fraction, my note can get quite lengthy because there's a lot of things you have to cover. Again, there are guidelines that you have to make sure you hit all of the categories. So first and foremost, we're going to diurese with IV Lasix. Now, the dose trial is how we know exactly how we should be dosing our Lasix. So this study sought to evaluate the safety and efficacy of two strategies for furosemide or Lasix dosing in patients with acute decompensated heart failure. Number one, the route of administration, either Q12-hour dosing boluses or a continuous infusion. And also dosing, looking at low intensification of 1 times the home oral dose versus high intensification to 2.5 times the oral dose. Now that means that the patient is already coming in on furosemide at home. So this patient was not on any diuretic at home. So we're not really going to base the dosing on that. Typically we just start off with 40 milligrams and then do IV twice a day, monitor the response as well as urine output, basic metabolic panel, and electrolytes. So we're also going to monitor input, output, daily weight, basic metabolic panel, and magnesium level. You really want to make sure your potassium level is at around 4 and magnesium around 2.0. Make sure you order a 2,000 gram low sodium diet. Now, as far as his medications, I'm going to stop the amlodipine. The brand name is Norvasc. In general, calcium channel blockers should be avoided for patients with low ejection fraction. But also, it's just there's better medications that we actually need to put the patient on. So I want to make sure we have enough blood pressure room. So first thing I do is I get rid of the Norvasc. And we're going to start an ACE inhibitor, such as lisinopril. Now, there's a few to choose from, but I'm going to go with lisinopril 10 milligrams daily. And now another thing, you can consider starting an ARNI, and that is the angiotensin receptor neprilysin inhibitor, which is sacubitril valsartan. The brand name is called Entresto. So you could just start with that to begin with. It kind of depends. That medication is quite expensive, so you really have to make sure the patient's going to be able to be compliant with getting that medication. Otherwise, we can start on lisinopril, and we can always change the medication down the road. Now, the patient is on metoprolol tartrate, which is not an evidence-based beta blocker, so that needs to be discontinued. This is definitely an extremely important point, that you choose an evidence-based beta blocker, and that is carvedilol, Topol XL, and bisoprolol. So if you have a lot of room for blood pressure, you might want to choose Coreg. It's a bit stronger. It has alpha blocking properties and beta blocking properties. So you could choose that. If you really don't have a lot of blood pressure room, maybe just go with Topol XL. Another thing you need to document, you don't have to start them on an aldosterone antagonist right now, but you need to document that you've considered starting it. I don't like to throw a whole lot of pills at patients at once in the beginning, so at least address it. Spironolactone is one of the drugs in this classification, and before discharge, make sure the patient's creatinine remains stable, less than 2.5, and a potassium less than 5, because those are definite contraindications to this medication. Another thing you're going to have to do with an ejection fraction of 35% or less, you need to refer them to cardiac rehab. And another thing that I do while the patient's in the hospital is consult the heart failure nurse so that they can give some extra patient and caregiver information They go through a whole lot of medication teaching and dietary teaching, and they also set the patient up with outpatient transitions of care, is what our facility calls it. And another thing I didn't write down here that's extremely important is to make sure at discharge your patient has a follow-up appointment within 7 days. It's not enough to just put on the discharge instructions, follow up with cardiology in 7 days. They must have a date, a time, a location, a provider, and state the words that they're following up with this provider for heart failure follow-up. That is extremely important to make sure that the patient does not get lost to follow-up. The patient should be reevaluated in 7 days. They'll likely get basic metabolic panel and magnesium blood work done at that visit, maybe even an EKG check. But you definitely want to have that visit to make sure their blood pressure is stable and that they're tolerating all these medications. If they are tolerating these medications, we want to up-titrate them. You don't want to see the patient on the same low-dose medications, over a year. You want to titrate these medications to the best that the patient can tolerate. And then let's not forget some of the other diagnoses. So when you're writing your consult note, your first diagnosis is the acute decompensated heart failure with reduced EF, and you have a whole big plan for that. Then you have to have more diagnoses than that. You cannot just write one diagnosis and walk away. You have to have your supporting diagnoses. So number 2 is coronary artery disease. And this is how I would write it in my note. History of LAD stent, no chest pain. Cyclotroponin, we only have one out of the ER, so I'd like to get 1 or 2 more, depending on how stable they are. Now he has mild left ventricular hypokinesis on the echo, so I'm going to consider an ischemic evaluation before discharge to evaluate and investigate an ischemic cause for this reduced ejection fraction. So it's important to come up with why do we feel that the patient did go into acute new onset heart failure with reduced ejection fraction. There are a multitude of causes, but one big one would be, does he have worsening of coronary artery disease? So you may want to proceed with a nuclear stress test before discharge, depending on how the patient fares during his hospitalization. But for right now, you're going to continue his aspirin, his statin, and his beta blocker. Then your third ICD-10 diagnosis is essential hypertension. You could also say uncontrolled hypertension, which is elevated. Monitor with current medication changes and IV diuretic. So that's how you're addressing that you see that the blood pressure is high, but you're starting some new medications, and you're also giving the patient a diuretic, which will also bring the blood pressure down. And the last diagnosis that you need to address is dyslipidemia, and relate that the patient is on Lipitor 40 milligram nightly. So on that, we'll check liver function tests and a fasting lipid panel if the patient hasn't had this in a while. So now that you've evaluated the patient, you've written up your consult note, now you will continue to evaluate the patient while they're admitted and follow along with their progress. So thank you for your attention and for following along with this case study. Stay tuned for more videos. See you next time, guys.